Hello, everyone. My name is Jude Kong, and I'm the director of the Africa, Canada Artificial Intelligence and Data Innovation Consortium, as well as an assistant professor at York University. Our summation is Summation 3891. And the title of my presentation is Leveraging Responsible, Explainable, and Local Artificial Intelligence Solutions for Clinical Public Health in Africa, Implications for Policies, and Lessons Learned from the ACADIC project. By ACADIC, I mean the Africa, Canada Artificial Intelligence and Data Innovation Consortium. The countries of impact of ACADIC project are Botswana, Cameroon, Eswatini, Mozambique, Namibia, Nigeria, Rwanda, South Africa, and Zimbabwe. To start, I would like to acknowledge the Canadian International Development Research Center, as well as the Swedish International Development Agency for the support that they gave us that led to the work that I'll be sharing with you today. I will equally want to acknowledge all our team leaders in the 9 African countries for the work that they have been doing, helping governments and communities to contain and manage the spread of COVID-19. I would also like to acknowledge my undergrad students, graduate students, and postdoc for the work that they have been doing with me that led to the results that I will be sharing with you today. To start with, I would like to start by situating myself in a community, type of community that I feel that artificial intelligence will play a big role in helping. I want to start by where I was born and my community and how I feel that artificial intelligence can be used to give meaning to someone or to be able to strengthen the healthcare system in communities like mine. I was born in Cameroon in a small village called Shish. And in Cameroon is divided into provinces, and each province is divided into division, provinces or region, as they are now called, and each region is divided into divisions. Each division is divided into subdivisions. So I was under the Jackie subdivision. She is a village under Jackie subdivision. And at the time I was growing, each subdivision had one public hospital with one doctor. Now, what that means that if you are far away in Shi or other places that are far away from the central system, the hospital was located in Jackie. If you are sick, you have to be carried to Jackie. Now, most of the time when you are brought to the main hospital, you may come there when the doctor is not there. Or you may come there and they ask you to move to the nearby, which was the divisional capital, Kumbu, because they were private hospital there and they could have some specialists. Most of the time, before people get there, they may die on the way. In my own community, and this is my community here, where we live happily, cultivate crops here, sell content. If somebody was sick here, there was one person at that time when I was growing up in the village with a car. They'll have to go and knock that person's door to carry that person to the hospital in Jackie. Most of the time, if you go there and the person is already carrying another person, someone may end up dying. Or people will have to carry the person on their back and the person could die on the way. Most often, in small communities like mine, when government give them schools or hospital, the community have to mold blocks, construct the schools, hire teachers, hire doctors, hire nurses. And this here is one example of a school I'm building, but then with support from community, it's about communal work. But the point I'm trying to make with this is my community is not unique. It's general in the global south and even somewhere in the global north. My community, as many communities in the global south, if something were to happen to it, it doesn't affect someone in Yaoundé. If this community was completely wiped out, it would not touch anybody in Yaoundé or in Douala or in New York or in Seattle. Life will go on as normal. But what drives me, what got me into research and what drives me is giving meaning to someone from my community or from a community like mine when you look at the future of being human. I try to provide meaning to that. And I feel that artificial intelligence toolkit can be useful in strengthening the healthcare system in a community like mine, in ensuring that the lives that are lost out of negligence or things that could be prevented should not be lost. Why do I think the old ways of modeling diseases or in these communities have not been very efficient? Well, we all know that the traditional approach that currently inform risk assessment and management strategies are reactive rather than proactive. These approaches have proven to be inadequate for dealing with the challenges presented by the systematic nature of risks and vulnerability. One could talk about the multifaceted interconnectedness of disease outbreaks, poorly understood breadth of population exposure, and profound nuance and detail of vulnerability. Thus, it is but reasonable that we need to fundamentally redesign, and we need a knowledge and paradigm shift in thinking with new conceptualizations, adaptive models, and operational tools that incorporate the systemic nature of risk in an objective, systematic, and comprehensive manner, and focuses on the most vulnerable, extending past individual patients to entire populations and geographies across lifespans. And what I believe strongly is that with AI-based technologies having the capability to enable the function of dynamic models that can automatically process information and provide forecast based on their analysis and evolving data, they hold a key to solving issues or strengthening healthcare system in communities like mine. And so for that reason, today I will be sharing with you or demonstrating what I've been able to do with our team and with funding from the IDRC and CDAM, which is I will demonstrate how AI and big data analytics can help address clinical, public, and global health needs in Africa, leveraging and capitalizing on the work, like I mentioned, that we have been doing with policymakers in Botswana, Cameroon, Canada, Eswatini, Mozambique, Namibia, Nigeria, Rwanda, South Africa, Zambia, and Zimbabwe. In particular, I will present the work that we have done in infectious disease monitoring, earlier warning systems, population health and risk management, and evidence-informed decision-making and intervention, as well as public health laboratory innovation. To start with, I want to say that the work that we have done, and thanks to the IDRC for the support and CDAM, have been covered by major international and national media. We have been spotlighted in the global north as well as the global south as major research innovation leaders. Most of our team leaders in the various countries we find in South Africa, in Rwanda, in Cameroon. The framework that we use have three spheres, as I may put it. We have the inner core, we have the medium core, and an outer core. In the inner core, that's where we ask ethical questions. There are three questions we ask ourselves before we move on to even collecting data, or to say if we need an artificial intelligence toolkit. The first question is always, is it responsible and ethical for policy and regulations? And our team, we have a multidisciplinary team that have AI governance experts as well as lawyers with us that asked all these questions together. By responsible and ethical for policy and regulation, what we mean is it accountable? Is it auditable? Is it compliant? Is it ethical? Is it respectful? Is it safe? Is it secure? Once this is answered, the next question we ask ourselves is it locally relevant and informed for the community? By local relevant, I mean, is it autonomous? Is it caring? Is it connecting? Is it decolonized? Is it human and community-centered? Is it inclusive? Is it intentional? Is it intersectional? Is it just? Is it practical? Is it protecting? Is it process-based? Is it sustainable? Once this is answered, we move on to ask, is it explainable to the society at large? By explainable, we mean, is it equitable? Is it fair? Is it interpretable? Is it reliable? Is it reproducible? Is it transparent? Is it trustworthy? And is it unbiased? Once we answer this core question to the core, if we realize that everything is yes, 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 then we move on to collecting data, which will now move to the medium core. But I want to say that if there is a no, we do not go on to come up with artificial intelligence solution to solve the issue. But once all of this is a yes, we move on to collect data. We design and deploy our artificial intelligence solutions. Once we deploy them, we monitor the performance of these artificial intelligence solution and continue to monitor them. And because as data evolve, we feedback the data because they continuously update, analyzed based on incoming data and provide projections. And so we continue to do that in the cycle, and that's testing the cycle. This is a framework we have used so far in the work we have been doing in Africa, which we believe that if this framework is adopted, it will be used to come up with responsible artificial intelligence solution that will help strengthen the healthcare system in the global south. We use the word real AI for GS. Real, because we believe that for artificial intelligence solutions to really be responsible, we need to have that they're responsible, they're local, they're explainable. When these core questions that I started by asking are answered, then we consider that's real AI for the global south. And that's what we have done in Africa, and that's what we intend to do in the entire global south as we move forward. I will now start by talking to you about or demonstrating some of the work we have done in infectious disease monitoring using artificial intelligence, just to demonstrate an example of how responsible artificial intelligence can help strengthen the healthcare system. So we'll start with infectious disease monitoring. When we started with, the first thing was knowing the communities that we care so much about, vulnerable communities, because of lack of healthcare, because of a weak healthcare system. There's always a lot of underreporting. And as an example here, we started with COVID-19. And we know fully well that there was going to be underreporting. But because we have a multidisciplinary team within us, our mathematical modelers start by using a mechanistic model that take into account, if you look at the first compartment here, it takes into account the incident cases, this accumulative number of incident cases. Then these incident cases are further broken down into the mild cases that are reported and the severe cases that are reported. So the CK here takes into account the change in severe cases. And then when you look at this, then we have the exposed classes, those who are just exposed here, which this is the transmission rate written in terms of the basic reproduction number, and the basic reproduction number was computed using the next generation metrics and then attached here from this relationship. And then we have here the IM here is the mild cases, the S here is the severe infectious cases, and these are asymptomatic cases. This block diagram here, or this compartment here, has people that are susceptible, exposed. So when you're susceptible, after you get in contact with a disease, you become exposed. Then after you become exposed, then you become infectious or asymptomatic. In infectious, we break the infectious into two compartments, severe and mild. And then after a time, you can recover. So we use this model in order to estimate the underreported values. And what we found out that was that the overall report rate in Africa was 5.37 with a standard deviation of 5.71 among all countries, with the highest of 30.41 in Libya and lowest of 0.02 in Sao Tome and Principe. We estimated that the mean report ratio of severe infections was 38.21 with the highest of 62.23 in Cameroon and lowest of 5.33 in Togo. We equally estimate that the mean report ratio of mild infections was 13.74 with a standard deviation of 14.45 with the highest of 47.83 in Benin and the lowest of 0% in Mauritania. Once we were now able to have an an accurate count estimate of the spread. Now, when I showed that, that was for at the country level, but I want to say that we did this at the local level for each local communities. We did that for each local community, estimated that. And then we work with pastors, priests, all policymakers in local communities to ask the type of question, what would people want to see as the pandemic is spreading? They inform us, and we came up with a dashboard for local communities to be able to see what was happening at the local level and at the country level. Here, I'm just sharing an example of the one for South Africa, where you could have the provincial breakdown, the county breakdown, or the subdivisional breakdown, city breakdown. Here we have Gauteng Hospital, vaccination status within each local communities, the risk for the first wave, as I will show some of the work that we did with artificial intelligence that led to that, how people were feeling using social media data, and every little detail that people wanted at each local communities, including where the hotspots were. So we put that in all dashboards, and each local community had a dashboard that we came up with in the 9 African countries that we were working in. The first thing was policymakers wanted from us was, can you let us know, after we provided the information, where they could see how the cases are evolving? They could know where the peaks will occur. They could know if the hospital system will be overwhelmed. The next thing was, can you let us know where the hotspots are? And we used a Gaussian mixture model to cluster the data and be able to identify hotspots. And as they keep on evolving with time, our analysis evolved with time and produced the hotspots, so that in real time, policymakers knew exactly where the hotspots were, given the data that we had. And thank God we were on the table with them, and we could inform data to be collected in a disaggregated way, or we could collect disaggregated data. So this is what this work was published, and the title was Big Data and Artificial Intelligence-Based Hotspot Analysis of COVID in Gauteng. But we did this for each local community. I'm just bringing the case of Gauteng. The next thing that we did was, now, after policymakers were aware of the hotspot, the next question to us was, when should we expect another wave if we succeed in this one? And this was a difficult question. So we worked with them to come up with an earlier warning framework. And our framework predicts 14 days ahead of time. And I must say that since we came up with this prior to the third wave in South Africa, in other countries, this framework have been very reliable in predicting subsequent waves. In our framework, we collect data from Twitter, Reddit, or local social media. We collect hospital data. At some point we use Google mobility data, but now we replace that. We have done a relationship now, because we know Google mobility data will not continuously be there. We have found a correlation between, an association between Google mobility data as well as the microeconomic keywords from Twitter. And now we are gradually replacing that with those microeconomic terms. So we use all this data, then we equally collect the daily data from hospitals and local communities. We correct the daily reported data so that we have the accurate count using the model that we had earlier on. We convert this social media data, all the data that we have, into a long and short-term data structure. Once we do this, we now feed it into a recurrent neural network with long and short-term memory, train the model, and I have the model predict 14 days or project 14 days case data. And then we compare that to the actual current data, reported data that we estimated. And we now determine thresholds based on the past outbreak, where we had high risk, low risk, and medium risk, such that policymakers should know what to expect. If it's high risk, it means that in 14 days or so, there is a risk of an outbreak. And we have been able to predict this for a while, and we have actually adjusted this, and we're now able to do this 1 month ahead of time. Once policymakers, we did that, we are now just showcasing one thing here. We have now moved on to use the same tool, again, to predict most re-emerging infectious disease. We are predicting re-emerging malaria, re-emerging monkeypox, re-emerging cholera. We tap into Google data, social media data, and use the same model that we have there, and we're able to predict this in real time. I must say that we're doing this around the world, the flu as well, and we're doing this very accurately. Our model is able to predict this accurately in real time. So we are this update in real time every day. We are able to take all of this and provide this information. Now, where we are moving to is to be able to predict emerging infectious disease. We are not yet there, but we are now at this point able to predict re-emerging infectious disease in these areas. The next question or the next worry was from policymaker was population health and risk management. How do we manage risks? And the greatest thing was on precision public health. And this is where I think artificial intelligence will play a big role, given my experience in precision public health. By precision public health, the aim of precision public, as we know, is always to collect large quantities of health data belonging to a diverse set of individuals for the purpose of analyzing the data using artificial intelligence to identify various subpopulations and their health characteristics, risk factors, and response to health interventions. This was very, very important to policymakers. But with the help of artificial intelligence, we could get this one-dimensional data and then disaggregate into two-dimensional data and inform policies. This is an example of where we got one-dimensional data for vaccine rollout. We break it down into the different age group. South Africa and into more severe and less severe cases, breaking down into 5 classes based on the various races in South Africa, the 5 races per se. And we're able to inform as to what age group, what race, and what gender should be targeted for vaccine. Based on our algorithm, you could see here, white men, this is just class 1 men here, white men of greater than 75. Now, why men white? Because the life expectancy of Black South Africans around 60-something. And so, but this point out to around 70-something as a risk. Men, the class is white, second here, and men here, this is men, where at the high risk, the most severe. And so this is how we could take this data and train a model to be able to disaggregate this data and inform policies in this way, the risk policy, and we could manage risks given the low dose of vaccine that South Africa had and other African countries. Another area where we did a lot of work was evidence-informed decision-making and interventions at the various levels. The first thing when we started, after we had estimated true case count, was policymakers were wondering in Africa, do we really even have COVID, as you are saying this, or what is happening here? And one thing we illustrate and it was to look at what factors are driving the dynamics in my country where my cases are going slowly, in other countries going very fast. What should I know? What should I control? The first thing was, if you look at this data here, I decided to put this for Australia, Nigeria, and South Africa. But when we did this for local communities, and we saw that the initial trajectories were different across communities. If you look at what we have for South Africa, Australia, and Nigeria, you realize that the trajectory here in South Africa starts slowly, and at some point it started to speed up. In Australia, it just went up high. In Nigeria, the slope was almost constant throughout, and but not really constant to say. But if you look at this, it's almost constant slope. And then the question here would be, is it because of certain policies that were put in by the local authorities that led to these dynamics or trajectory? But our thought process was, no, the initial trajectory influenced the policies. So the policies on their own cannot influence the initial trajectory. And so we thought that pre-existing country characteristics, by pre-existing country characteristics, I mean, could be demographic, socioeconomic variables, environmental variables, health variables, play a role in these initial trajectories. And we investigated and realized that indeed, and this was published in +1 here, indeed, the number of young people in the country, the Gini index of the country, the number of people living in city agglomerates, and the use of social media to organize offline action play a very big role in the initial trajectory. Now, we consider many factors, much more than this, and we eliminated them for collinearities when we started our analysis. Again, p-value is a term that is very relative, but just picking out these four as standing out. Once we were able to tell policymakers what was driving the initial trajectory, the next thing they wanted to know was, before the first peak, are we going to overwhelm our hospital capacity? And when we asked the various questions in the central core of our AI model, at this point, we decided to use an agent-based model using the subway analogy, where for each local community, we took the total population as a whole. And when we take the total population as a whole, we consider disease spreading at this top layer here, where you have susceptible people, exposed, infected, and then confirmed COVID cases. And then this is where they self-isolate. It could be you self-isolate and then you recover or you die. So we break this down, we break a framework of this one. And then we have the hospital system here, where in the hospital you have the normal ward, and you have the ICU, and you have the ventilation. And if you're in the normal ward, you can the hospital can decide based on your situation to send you to self-isolate at home. Or you could use the hospital bed, and you decide at some point, if your cases are not very severe, if your cases become very severe, you could be sent to the ICU unit. And once it becomes less severe, you could be sent back to the main ward. And at some point, you'll be discharged or sent home to self-isolate. If you were in the ICU unit and it's very severe, you could be given a ventilator. And after a while, you could be sent back to the ICU unit if things become a little bit less severe, but still severe. And as you become less severe, you could be discharged, sent back to the main ward. And the whole process continues. So we did this, and we treated each and every individual as an agent in South Africa. And our main aim was to always project the need for hospital resources, ventilators, hospital beds. For just as an example here, and I want you to focus on this red line here. All of these lines here represent the ventilators, patient with ventilators, the number of beds, patient with beds, on beds, and then the death. But I want you to focus on the red here, which is the number of deaths. This was a projection we did earlier on in Gauteng, actually, in South Africa. And when we did this projection, this was without implementing any policy. And then we went on to implement different policies, just presenting one here to say, if you were to increase the capacity of ventilators at hospital beds by 25 to 35%, then you see the number of deaths here reduced drastically, a lot. And if you were to move on to do earlier discharge, just like we have there, you see the death completely reduced to zero. And if you do earlier discharge in 2 stages, the death completely almost boiled down to zero here. And so this was the model this was what we used to inform the management of hospital beds and ventilators across each local communities where we found ourselves. The next thing after we were able to do that, to ensure that they do not overwhelm their hospital system in the first wave, I'm looking at here, just presenting a situation in Canada, but if you look at here, this was the first peak. After this was averted and they went down the lockdown, things were controlled, the second wave came in South Africa and other countries. And the next question was, from policymakers to us, was, what is driving this second wave? What policy did I have in place that when I lifted led to this second wave? And what we did was we collected data on all the policies that were put in place. We collected data on some of the comorbidities that exist, or some of the factors, health, socioeconomic, environmental factors, including those we had used in the first wave to drive this, to figure out which of these was instrumental in driving the second wave. And we found out that the body mass index, fascia covering in a gathering of more than 4 people, restriction on gathering of more than 4 people, international travel, diabetes, restriction in gathering of more than 3 people, the lower respiratory infectious disease rates, UV radiation, pollution, and GHS index were responsible, the 10 major factors. There were many more factors that we ranked them, but these were the 10 major factors that were responsible in driving this outbreak here. This was published in scientific report. Once we explained that, vaccines became available at some point, and the major question was, can you help us with artificial intelligence to come up with a roll-out strategy? And we did this for the entire 9 countries that we were in at each local level. In the first case here, what we did here was in South Africa here, if you look at this, we use graphical neural network to be able to determine that if 0.2% of the adults are vaccinated, we will reduce the number of severe cases by 80%. And we now group this into different risk groups. And this was thanks to the artificial intelligence models that we used to break it down into different risk groups, where based on the age, the gender, and the race, as well as the comorbidity, we group people into different risk groups such that given the limited number of vaccines, we could do targeted vaccination. So artificial intelligence play a very big role in South Africa and the other African countries that we worked in informing policies or vaccination rollout strategies. The next thing when vaccine became available was that there were a lot of misinformation and disinformation spreading around social media. I belong to a lot of African social media group, and there were somewhere they said, in Ghana, there was one that said, oh, there's a green tea that will cure this. Don't listen to this. In Cameroon, there was the Afofo drink, where people say, if you have COVID, just drink Afofo. You don't take these vaccines. So there were a lot of misinformation spreading around the continent. Oh, COVID doesn't affect, it cannot withstand our Africa blood. It doesn't affect us or our temperature here. It's a white man disease. There were a lot of information spreading on social media, but what we could do sitting on the table with policymakers was, at each local community, can we know the topic that people are mostly talking about? What misinformation is being spread? If we know the topic, what's the sentiment? How are people reacting to it? And I must say that natural language processing play a very big role in this area, where we could tap into different social media topics that people were talking about, be it the South African local social media or the typical, or using Twitter, Reddit, and the popular ones, Facebook, that people are using. Once we tap, and as well as YouTube, once we tap into the data here, we did topic analysis and sentiment analysis in each different region, and then influence the conversations and each local communities, exactly inform what local authorities should go on radio station and talk about, because we knew the topics that were going on. We knew how people were reacting to different topics, and we could then counter that with the right information. And this play a very big role in the various African countries that we work in, the 9 African countries that we worked in, to inform policies. As we were using social media data in informing a lot of policies, like I talked about how natural language processing play a very big role, we realized that because we really care much about disaggregating data in terms of gender, race, and sexuality, one thing we realized was about gender, not the tools that we had to distinguish whether somebody was male or female. The data we are getting was not performing really well, if I may put it that way. Currently, what existed was, if you type from the text, you could use a BERT model, a bidirectional encoder representative from transformers, to determine whether somebody is male or female. But the accuracy was not high per se. And so working on that, we came up with a method paper where, in addition to what already exists that uses BERT, we use a vision transformer using the images that people post on their social media to be able to add to that and determine, well, if you put a cat, we'll consider as an unknown. Here, either female or male, when we train data, we hand labeled a lot of pictures, and then once we hand labeled that, we train our model to be able to determine male, female from that. And then once we did that, we combined both the bird model and the VIT model, the vision transformer model that's based on vision transformer, in order to predict and use a neural network in order to predict whether somebody is male or female. And we got a very high accuracy compared to the existing model. The text classification model, for instance, the image classification here, when we did our new VIT model, if you look at the accuracy here, in the image, we got 79.21, the text was 79.63. When we combine these two, we got 86.73, and so on. So we were now able to disaggregate data as we get it from social media to know whether gender, because this was really very important, and natural language processing, we realized that was playing a big role in informing policies in all these countries. Once this happened, policymakers now were worried. In Africa, the macroeconomic data is always collected quarterly. It became an issue within COVID. And most of the government authorities were wondering whether there was a way to inform microeconomic parameters within the pandemic. Can we know the level of unemployment? And the first thing we had done was that we had found out an association between Google Mobility Index as well as the certain keywords that we picked up. And we found a very strong correlation. Once we did that, we know that those keywords could be used in the future going forward in terms of Google Mobility Data Index. Then what we did, we went backward in time and trained a model using particular keyword to find out whether, so we use a bird model here, whether there was a association between unemployment and the keywords that we had. And we trained a model and it performed really well. And then we were then using that particular model as well as sentiment to predict the unemployment in all of these countries, as well as many other microeconomics matrices that we were able to predict. And this is a case of unemployment in Gauteng, South Africa, and we're able to predict really well unemployment. This is training set here. And then from here, where you have this is where this orange line, this is where we are now casting. And this is a model that have been used throughout the pandemic to inform microeconomics matrices within these countries. We just recently compiled one of these, but we use this in all the countries that we're working in to inform policies. So in order to conclude and the way forward, AI appears to have enormous potential for the management of disease and other emergencies, and their role is anticipated to increase in the future. As I have shown to you, artificial intelligence can be used to track the spread of the virus in real time and plan and lift public health intervention accordingly, monitor their effectiveness, repurpose old compounds and discover new drugs, as well as identify potential vaccine candidates and enhance the response of communities and territories to the ongoing pandemic. I must add that these imaging approaches can be exploited together with the classical surveillance, not just as silos, but all combined together. We should integrate this with the classical ones that exist right now. To have an integrated system. I will equally more from there to say that the approach we use in Africa, we have documented this approach, the various stages of using artificial intelligence to inform a disease outbreak. We have written all of these and the methodology in a UNESCO, in this UNESCO toolkit, and this can be found here. Thank you very much. Merci beaucoup.